Hello, my name is Kassandra Romas and welcome to 30 Medical Minutes. Each year, thousands of people in the United States have knee replacement surgery, about 600,000 to be exact. Why do they need knee replacements? One thinks about accidents and sports-related injuries, but there are other medical factors that cause inflammation of joints and thus deterioration of cartilage. These issues lead to pain and even disabilities, necessitating the consideration of knee replacements. Our guest today is Dr. Dr. Leary, orthopedic surgeon, who is affiliated with Overlook Medical Center in Summit, New Jersey. Dr. Leary is going to describe the scope of knee replacement surgical procedures, noting that both total and partial replacements are available to patients. Of note, Dr. Leary is going to describe the amazing Makoplasty robotic system that is being utilized to provide unparalleled accuracy while replacing the damaged areas of the knee. Please stay tuned to listen to Dr. Dr. Leary discuss the scope of knee replacements and the major advancements that have been made to the benefit of the grateful patient. And now, let's welcome Dr. Leary to 30 Medical Minutes. Hello, Dr. Leary. Thank you for joining us today.
Thank you so much for the invitation, Cassandra. I really appreciate it.
Okay, well, our topic today is knee replacements, and I mentioned that you're an orthopedic surgeon. Can you tell us a little bit about yourself and your background?
Yeah, I'm actually a New Jersey native. I grew up in Somerset County. I did my undergrad training down at Liberty University in Virginia. From there, went on and did my medical school and orthopedic residency at Rutgers, Robert Wood Johnson in New Brunswick. I went active duty military with the Air Force after that, did 2 combat tours to Afghanistan. And during that time also completed 1 fellowship, which is advanced specialty training in orthopedic trauma, which is severely broken bones and orthopedic injuries. And post-military, I went back and did a 2nd year of specialty training in hip and knee replacement and treatment of arthritis down in Tampa, Florida. Once I completed that, I moved back home and I've set up practice currently in Millburn, New Jersey. And actually, at the beginning of this year, I'm going to be joining the staff at Overlook Hospital, where I'll be seeing patients there as well.
Okay, wow. First of all, thank you for your service, Dr. Leary. And I am totally amazed that you were providing care in the traumatic field experiences. And so you obviously had a lot of very serious situations to oversee and take care of.
Yeah, it's a much more controlled environment back here in the States, and I'm just grateful to be home, and but also glad I had the chance to serve and really take care of some really amazing soldiers. Well,
thank you again. So we're talking about knee replacements. Can you tell us why people need to have knee replacements? I mean, it seems pretty common these days.
Yeah, you know, I think it is important because this is such a common problem with arthritis of the knee, and what we know is, I just want to show you some information that we have here.
Sure.
Is that a study was done a couple years ago projecting the future needs for hip and knee replacement in the U.S. And what it showed is by the year 2030, there's going to be about an 800% increase in the need for hip and knee replacement in this country. And that's just a tremendous number when you think about it.
Yeah, and that's huge.
Huge. And really the function of that is the population change we're seeing as the baby boomers get older. There's a huge shift in the population in this country, and arthritis tends to be, but not always, more prevalent in older patients. But we're also seeing a huge increase, as you see on this graph, in arthritis and the need for total knee replacements in younger patients too. And you see that in the lighter colored here, which is younger patients in the U.S. Between the ages of 45 and 65, as opposed to the darker color in that graph, which is the over 65 age group. So not only are the older patients in the U.S. needing it, but we're also seeing a tremendous increase in the need in younger patients too. And we also see that here in the need for hip replacement. Same idea is that younger patients in that sort of 45 to 65-year-old age group are needing these operations. And also, you know, we have as we see these younger population, the expectations have changed also. Patients want to be back sooner, back to work, back to their active lifestyles. And so the surgeries have needed to change too to sort of accommodate that and get patients back to the activity levels that they expect.
Right. Okay. I'm going to back up a little bit, Dr.
Sure.
Leary. You're saying, and as I said in my introduction, people assume that you need a knee replacement because you had a sports injury or you were in a car accident, and that, of course, is obvious that that does happen.
Yeah.
But you're saying that the real cause for the need for knee replacements is because of arthritis.
Correct.
Or osteoarthritis. So it's a medical condition that is the major factor that produces the need for knee replacements. Is that correct?
Yeah, and I think it's important that we understand what arthritis really is.
Yeah, can you explain that for us again?
So arthritis, by definition, is an inflammation of the joint leading to cartilage loss. And it's important, and we can use this model as an example. The ends of the joints on any of your bones, fingers, hips, knees, are covered in a very smooth cartilage, which is called articular cartilage. It's a perfectly smooth surface, very low friction.
Sure.
And there's a little bit of fluid in there called synovial fluid, which acts as a lubricant, and it creates this low friction environment which allows the joints to move, flex, and extend very smoothly without pain.
Okay.
Arthritis, by definition, is when that cartilage starts to go bad. If you could imagine, if I took a piece of sandpaper and started working away at this, eventually that cartilage gets eroded to the point that you end up with exposed bone underneath. You no longer have that nice smooth surface.
That's pretty ugly.
Now you have this very high friction environment, if you will. It's like two pieces of sandpaper rubbing against each other, which doesn't function very well and is also very painful to the patient.
Right. So does this show a model of very bad case of deterioration?
Yes, this would be once that cartilage is completely gone and you've actually exposed the bone underneath. That's sort of end stage arthritis.
Okay, so when you're moving and you're walking and everything, the bone goes up like that and it rubs right up against there. And
Correct.
Are there nerves in there?
There are nerves in the lining around the joint, and as the joint gets inflamed from all this friction and loss of cartilage, the whole knee becomes very painful, and it's usually worse with activity because you're just grinding away on that exposed bone.
Right.
And
so the inflammation comes from what part?
It's the whole process of the knee recognizing that there's an injury, meaning cartilage loss, and not having the ability to repair that injury. So it just creates this inflammatory environment as it tries to heal a problem that the body does not have the ability to heal. And it creates this just chronic inflammation and chronic pain that is a downhill slope. It does not get better.
It does not get better.
Correct.
So it's not like you can rest, put your knee up and everything like that and hope it's going to be better tomorrow.
No, it may help the symptoms, but the underlying problem's not going away.
Okay. Thus necessitating the wonderful knee replacement component.
If we get to that point.
If we get to that point.
Right. Early on, there's other things we can do, but the end stage, the end game of this is really, if you want to take care of the problem, is knee replacement.
To repeat what you said about some of the factors, you were indicating that age isn't the only factor.
Correct.
What other factors cause inflammation, the arthritis coming about?
Right. Like we discussed, age is definitely a reason. As the more you use it, as you get older, it's a simple wear and tear type issue. You drive your car enough to you lose tire tread, right? It would be a similar analogy.
Okay.
But there are other factors. Obesity absolutely plays a role. The heavier you are, these joints are seeing more stress, and it's just simple physics. If you're putting more stress on the joints, you're more inclined to wear away the cartilage. That's not to say that every overweight person is going to develop arthritis, but it certainly increases the likelihood. We earlier had alluded to trauma or injuries, sports injuries. An actual injury, a car accident, something like that, couldn't cause an injury to the cartilage, which would accelerate the deterioration over time.
I see. Okay.
So that absolutely plays a role.
Okay.
There's other hereditary conditions and diseases such as rheumatoid arthritis, other immune diseases which can attack the cartilage, muscle weakness, and there's really a whole list of other rarer conditions that can do it. The most common would be osteoarthritis, though, which is simple wear and tear.
So what I can see from our chart, we have age, obesity, joint injuries, and muscle weakness, which I don't quite understand, and heredity. What do you mean by muscle weakness? Is that somebody who doesn't exercise, or somebody who just, has a very flaccid type of
No, I think
physique?
more it would be a function of that if you have various conditions which cause weakness, it may result in the mechanics of the joint not working appropriately, so it would cause certain parts of the knee to wear out sooner just because the biomechanics aren't functioning the way they should if the muscles were firing at 100%.
But on the other hand, exercise is still good, though.
Absolutely. I certainly am not going to encourage anyone to stop exercising to save their knees, because it's well proven that the cardiovascular benefits and other benefits are certainly outweigh that. I would not encourage anyone not to exercise just because they think they might develop arthritis down the road.
Okay, so somebody is having aches and pains and stiffness, and their knees seem to be swollen and everything like that. When should they go to you, and how would you diagnose that they have, what extent they have a knee problem? Yeah,
I would encourage anyone who's having chronic pain, meaning more than a day or two, or an actual injury, to come in and have it looked at. The easiest way and the most common way we tend to diagnose this is with x-rays. I tend to take x-rays of the patient in a standing position as well as a sitting position, because it helps give me more information what's actually happening when the patient's walking on the joint. Sometimes, though, other doctors are referring patients to me, and they've already had other procedures, like arthroscopic procedures, where the patient has actually had a camera in the joint. And gives me real feedback, because I can actually look at photographs of the amount of damage, and that's very useful as well.
Okay, so you use x-rays as well as, and if somebody's already done some arthroscopic surgery, you have the benefit of knowing what the condition is from there.
Not necessary, but it is definitely a bonus and makes diagnosis easier and more accurate.
Okay, fine. So if you're getting a diagnosis and somebody is just, can't standing it anymore, oh, I suppose that's a pun. Sorry about that. Then what are you going to suggest that they do to get better? What treatment options do you have?
Yeah, we have a lot of different options. I like to call it the ladder of therapy, because it follows a very stepwise progression. For people who have a weight problem, we certainly encourage weight loss, because, again, getting back to that whole simple physics, if you're carrying less weight, the joint's seeing less stress, it's going to cause less wear and less pain. Modifying activities. If a patient has arthritis, running's probably not the best idea. You don't need to be pounding away, but we still want patients to exercise, stay fit, keep the joints mobile. So maybe changing to swimming or biking.
Oh, that's a good idea.
Something like that, as opposed to running 20 miles. Certainly just simple things like that.
It sounds like it's common sense, actually, what you're saying.
Yeah, but at the same time, some people just need to sort of be encouraged that, or just understand the cause and effect of what the damage.
So they don't have to be stubbornly saying, "I'm going to keep on running no matter what."
No matter what. So yeah, there's certainly other options that would provide as much benefit, but not as much stress on the joints. There are braces that we use in certain patients. They can be very effective in alleviating the pain. What I find in my practice, anyway, over time, is a lot of patients just get tired of wearing braces all the time. It can be cumbersome. Trying to find braces that fit nicely under clothing becomes a chore at times. They are effective in maybe slowing down progression as well as helping with pain. But again, I think the compliance, and most patients just don't want to wear a brace for 10 years.
Okay, well, let me ask you, what does a brace look like? Is it like an ACE bandage that goes around your knee?
No, it's bigger than that. It's actually an actual rigid structure, Velcro straps, and a hinge.
So I see.
This is bulkier than just sliding up like a compression sleeve.
Okay, so all right.
Because the braces we use for arthritis actually apply a force to the knee to help offset some of the stress. So it has to be fairly rigid to do that. And again, it can become cumbersome at times.
And it molds around the upper and the lower part of the knee.
It goes on both sides of the knee.
Both sides. Okay, great. And I'm sorry I interrupted you. We were talking about bracing and so forth. And what other options do we have?
Medications. So we most commonly would be anti-inflammatory medications, your Motrins, your Naprosins, Aleve, Advil, things like that. Which again,
is that temporary?
Yeah, it's going to help bring down the inflammation. Again, not curing the problem, just helping symptomatically make it less painful. Use of a walker or a cane, which again, by taking stress off of the damaged joint, will help with the symptoms, may prolong the life of that joint, but it does involve using that assistive device, which a lot of patients, especially highly active patients or younger patients, really don't find tolerable.
Right.
And as a last resort, once we've tried all these things, if you have progressive pain, debilitating pain, it's really affecting your daily life, we start having the surgery talk.
Okay, so surgery is something that people probably would want to avoid because everybody's afraid of an operation and so forth. But you're here to tell us that knee replacement surgery is not going to be as onerous as it has been in the past, right?
Correct. I think historically these have been operations people dreaded because they've always heard that they're so painful and the recovery is so long, and just really want to avoid at all costs. And things have really changed, even the way we do the procedures, the implants we're able to use, the medications and the pain management protocols that we use today have made these operations much more tolerable for the patient. And once you are recovered and through the initial post-op period, patients do really, really well. These operations are extremely successful at improving pain and returning function to patients, and people do really, really well with these.
Well, I think that it's very encouraging to hear that the surgical procedure and recovery is not as bad as one might anticipate, and the return to complete functionality sounds like it's very, very good.
Yeah, and again, like we discussed earlier, we're seeing the need for these operations in a younger, more active population. And patients return to doing all kinds of things. I have patients who still snow ski, play ice hockey, bike, mountain bike, walk as far as they want, play with their grandkids, really have a very normal life after this with much better pain and function than they had before the operation.
Well, that's great. Okay, so in my introduction, Dr. Leary, I mentioned that there can be a total knee replacement or a partial knee replacement. So why don't you describe when and where you would decide on which one to do?
Yeah. As a surgeon, I like to be able to organize and sort of compartmentalize the knee joint to keep my thought process organized. So what we really do in orthopedics is we break the knee up into 3 parts. We break it up into the inner part, the outer part, and the area that would be under the kneecap or the front of the knee.
Okay.
And then
wait, hold that up again. Show us what you mean again.
So you've got the inner part of the knee,
okay,
the outer part, and then this area, we don't have a kneecap on this model, but your kneecap would live right here. And so that would be the front part of the knee where the kneecap rubs, and that can develop arthritis as well.
Oh, okay, great. So you determine where the biggest part of inflammation occurs.
Right, and some people, the arthritis damages the entire knee, all 3 parts. Some people, it's much more focal. It only will be highly damaging to one part of the knee. And really, depending on how much of the knee is involved with the arthritis is how we decide what surgery would be best for the patient. And if you're going to look at that, a total knee replacement, which we have here, is a resurfacing of the entire knee, the entire damaged cartilage. And just to sort of rewind, I think one of the common misconceptions when we talk about knee replacement, people hear that and they think that we're going to actually cut here, and take their entire knee out.
Oh, I'm sure a lot of people think that.
And I hear that question a lot, and I think it's really a big misconception. What people need to understand is that a knee replacement is more of a knee resurfacing. What we're doing is we're taking that damaged cartilage out that lines the end of the joint, and it's not smooth anymore. And what we need to do is just put a new lining, a new coating to make it smooth again. And that's what goes on the end of the joint. You see it from the side there, around the perimeter of the joint, and it just creates a new smooth surface instead of having that rough, exposed bone.
I see.
And we do that on both sides because the cartilage is damaged on the tibia bone, so we replace that on the femur bone, and that's it. So it's just a resurfacing. We're not replacing all the bone.
You're not taking out the bone and cutting it out. What you're doing is that you're replacing the cartilage.
Right.
You're
just resurfacing
the cartilage so that it doesn't go bone on bone.
Correct. So it's just an easier way, I think, to understand it as opposed to, and I think when you see that, you realize it's not as big of an operation, I think, as some people have in their mind that it really is.
Well, I'll tell you, that picture is worth 1,000 words, Dr. Leary, because now I understand that a lot better.
And then, so this would be a total knee where we have to resurface the entire, both sides that we talked about, the inside, the outer part, and under the kneecap. However, in a patient who only has arthritis in one of those or 2 of those areas, what we have is we're able to do what we call a partial knee and just replace parts or the injured part of the knee, which you see in this model. So suppose they only had damage to the inner part, the rest of the knee looked fine. What we're able to do now using the robotics is very, very accurately just replace that injured area and leave the rest of the knee intact. What that provides is a less surgery, certainly, less damage to the knee, less recovery, less pain, and a much, much faster recovery.
Well, it makes a lot of sense if only one little portion of it is damaged, that you just treat that part, but it seems very difficult and very complicated to just work on that little section of the knee.
Yeah, and historically that has been the case. These are good operations, but there was a higher failure rate when these were done the traditional way of the surgeon just making a judgment call and using a guide to make the cut. What studies have shown is that for these to be successful operations, the implants need to be put in perfectly and the alignment of the leg needs to be corrected really with very little room for error. When done correctly, these are really good operations historically, but the difficulty has always been getting the implants in the exact right way. With the advent of robotics, we've been able to take those outliers out and really increase the accuracy with which we're able to do these operations, and therefore increasing the success with how long they last, and also increase the or decrease the recovery time and get patients back to activity much, much faster.
Okay, so I'm going to repeat what you just said, Dr. Leary. Dr. Leary is saying that partial knee replacements can be done now with robotic surgery, which provides to a very accurate replacement of the injured area and an implant that is precisely made to the, I suppose, the bone section, correct? Or the knee section.
Able to really customize it for the individual patient.
And because of that, you have a much more accurate and precise implant that leads to a faster recovery and almost 100% mobility after that. Is that correct?
Correct, and really increases the longevity of the implant too.
Oh, that's a good point. Okay, so I think this is absolutely amazing. I've never considered robotic surgery in connection with the knee, so I assume that you do a lot of these. Can you explain what the process is about?
Absolutely. The procedure starts once we've decided, in the office that a partial would be the right operation for a patient. The first step is sending them for a CAT scan, which is a fast study that's done. And we're able to make a three-dimensional model of their knee in the computer based on that CAT scan. Once we have that model, we're actually able to plan the entire operation before the patient's ever in the OR. We use that model, and you'll see some selected images here, and we can actually pick the sizes, show exactly where the cuts need to be, so we only take the bare minimum amount of bone, which is really good for the patients. Causes less damage, bone sparing. You see some more pictures here where we're looking at the femur, able to look at that model, show exactly where that component needs to go, demonstrate how the two would interact together with motion. And all that's done, again, before the patient is ever even brought to the OR. So I'm able to customize and fine-tune this plan without ever touching the patient. And that's a huge benefit, just because I'm able to really determine the accuracy and the right size implants and customize this plan for the individual patient.
Wow.
And that's something we never had access to before.
No, this is totally amazing.
And then what I can do, and you'll see on these pictures, is that we're able to actually see how the knee will move with the implants in.
Wow.
And again, make sure that the balance and the alignment is perfect before ever starting.
Wow. Okay. So what I understand then is that by taking the CAT scan and putting it into the computer, you are able to create a 3D customized, computerized model of exactly what you're going to do with all the measurements down to the last millimeter.
Correct.
Okay.
For that specific patient.
For
this is not a one-size-fits-all. We're customizing it. Exactly.
Okay. So now that you've done your model, what do you ask your patient to do? Do they have to prep in advance of this? Is this a one-day hospital procedure? Do they have to be an inpatient for a few days? And how does the surgery go?
So preoperatively, they're going to have some testing, blood work, EKG, chest x-ray, just to make sure they're safe for the anesthesia part.
Right.
The day of surgery, they come in. This is done as a same-day procedure. You're home for dinner that day, and which, again, has been really a huge change. Patients historically, years ago, used to spend a week in the hospital for a knee replacement, and now they're home walking out of the hospital in a couple hours.
That's unreal.
Yeah,
unreal.
It's just revolutionized the way we do these operations. And then post-op, even for the first 2 weeks, what we do is we send the physical therapist to their house. They work with them in the comfort of their own home.
Oh, good.
So they don't have to worry about going around trying to get the physical therapy, things like that. It's a very nice system we have at Overlook. that helps, from pre-op all the way through post-op, making sure patients really get the most optimal outcome from their operation.
Okay, fine. So I mentioned robots, but where does the robot come in?
Yeah. So again, I think we really need to define what the robot is.
Okay.
People, I think, see, like the Terminator holding a saw and trying to do this operation while the surgeon's standing in the background. And that's absolutely not what it is. The robot is really a mechanical arm with a high-speed burr on it, which we use to remove the bone to fit the implant. The entire surgery is still done by the surgeon. He is controlling the robotic arm. Mm-hmm. What the robotic arm does is it takes the plan that we created, and once we have started the surgery, we take some points on the actual patient. We're able to superimpose the patient's bone into the plan, and then the robot will only let us make the cuts that we have pre-planned before the operation. So there's no working outside of the plan. There's no outlier. It's very precise, and it will not let us make any cuts that we did not agree on or plan for before the surgery. So it decreases the room for error and increases the precision, like we discussed.
Wow, that is totally amazing. So you're moving the robotic arm that does the actual burring,
yeah.
And then the insertion of the implant.
Correct. So the robot is only used to make the cuts. As the surgeon, I'm still doing all the implantation of the replacement.
I got it.
And as we are doing that, we're fine-tuning the plan as we go. We do have the ability to change the plan on the fly while we're doing the operation.
Okay.
Again, we're customizing as we go, and the robot will only allow us to work within the confines of that plan.
That's totally amazing. What about pain management? Is there much pain after that? I mean, if we can talk about that in the last few minutes that we have.
Yeah. In the last few years, we've really changed the way we treat the pain, both pre and post-op. As you know, there's a really big problem with opioids and narcotic use in New Jersey and across the country, really. So we're really getting away from trying to use those kind of medicines trying to use those as little as possible, and use adjuncts or other medicines and other pain control methods to minimize the use for narcotics. And what we do is preoperatively, before you even have anesthesia, we start medicating with a couple different medications, like steroids, high-dose Tylenol, things like that. Mm-hmm. We also use nerve blocks before surgery, which help numb up the nerves, and those are long-acting, last for up to 1 to 2 days during the operation. So you're having much less pain and able to get moving right after surgery because those nerves are blocked. We also use a long-acting Novocaine, which lasts up for 72 hours, which I inject all around the surgical site before we close up the knee, which again provides up to 3 days of relief, which really helps, again, with pain control and really helps the patients get up and get moving early. And then post-operatively, we're using anti-inflammatories. We're using a different class of drugs that sort of modulate the way the nerves sense pain. And we do use some low-dose narcotic, but by using all these other medications, we're really able to minimize the need for narcotic use after surgery.
Thank you, Doctor. That's wonderful. Thank you for joining us today on 30 Medical Minutes and learning all about knee replacements.
Yeah.